Namaste बिटिया, हमेशा खुश रहो बिटिया. A very good morning to you all. Myself, JV'n Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine at Faculty of Homeopathic Science in JAYOTI VIDYAPEETH Women's University, Jaipur. In today's lecture, we are going to continue with the previous series of glomerulonephritis. In the previous lectures, we have discussed about nephrotic syndrome, we have discussed about nephritic syndrome, and also we have started with the spectrum of the various diseases, various changes that are occurring in the glomeruli. So in that series, we are going to continue from the previous lecture. Now in today's lecture, we will start with IgA nephropathy. Three types we have already discussed in the previous lecture, and we are starting from the fourth type, that is IgA nephropathy. IgA nephropathy and Henoch-Schilling purpura. IgA nephropathy is the most commonly recognized type of glomerulonephritis, and it can present in many ways. So IgA nephropathy is the most common recognized type of glomerulonephritis, and it can present in many ways. We have hematuria, that is the earliest sign and is the most universal. We have proteinuria that occurs later, that is a later feature, and we have hypertension that is very common. So we have hematuria, proteinuria, and hypertension. So there are three important features of IgA nephropathy: hematuria, proteinuria, and hypertension. In some of the cases, severe proteinuria or the loss of renal function occur. So in some of the cases, there is severe proteinuria and the loss of renal function that is occurring. It is common cause of end-stage renal disease, that is ESRD. The exacerbations in the young adults are acute, self-limiting, often with gross hematuria in association with minor respiratory infections. So if IgA nephropathy is occurring in the young adults, the exacerbations are acute and self-limiting, which stops by themselves and often occurs with gross hematuria. There is great hematuria in association with minor respiratory infections. The exacerbations are so acute as to resemble acute post-infectious glomerulonephritis. This we are going to discuss later in today's lecture itself. With fluid retention, there is hypertension and oliguria. There is fluid retention, hypertension, and oliguria with dark or red urine. The duration from clinical infection to nephritis is short. So the duration from the clinical infection to the nephritis is short, a few days or less. IgA nephropathy, it progresses rapidly and crescent formation may be seen. So IgA nephropathy, it progresses very rapidly and there is formation of crescent formation that can be seen. Systemic vasculitis in children and adults in response to infection is called as Henoch-Schilling purpura. So Henoch-Schilling purpura is a part of IgA nephropathy itself. And there is vasculitis, systemic vasculitis, that is inflammation of the blood vessels that can occur in the children and adult. All right. So this picture you are going to understand in the next slide, what it is and what does it mean. Just have a look at this picture. Now, IgA nephropathy, we have Henoch-Schilling purpura. Henoch-Schilling purpura is characterized by petechial rashes. So you can see the petechial rashes here. Cutaneous vasculitis that is typically affecting buttocks and the lower legs. Let's see at this picture. Buttocks and the lower legs are affected. There is abdominal pain, that is gastrointestinal vasculitis. We have mild glomerulonephritis indicated by hematuria, and we have renal biopsy that shows mesangial IgA deposition and appearances indistinguishable from acute IgA nephropathy. So in the renal biopsy, it shows mesangial IgA deposition and appearance indistinguishable from the acute IgA nephropathy. The response to immunosuppressive therapy is poor. And the management of less acute disease is to control of the blood pressure to prevent or retard the progressive renal disease. Now we come to the next, that is glomerulonephritis associated with infection. It is also called as mesangiocapillary glomerulonephritis. This is another form of glomerulonephritis, that is mesangiocapillary glomerulonephritis. It is subacute, it characterized by subacute bacterial infection, that is bacterial endocarditis, causes a variety of histopathological patterns of glomerulonephritis. So when the patient is affected by subacute bacterial infection, that is bacterial endocarditis, and it represents with a variety of histopathological patterns of glomerulonephritis, most typically with membranous and mesengiocapillary lesions, that is known as MCGM. Membranous and mesengiocapillary lesion, MCGM, with plentiful immunoglobulin deposition. Glomerulonephritis are these kind of glomerulonephritis are more commonly occurs in the following: hepatitis B infection, hepatitis C infection, schistosomiasis infection, leishmaniasis infection, malaria, and other chronic infections. Proving a causative relationship between the renal disease and infection in the individual, it is difficult. We come to the next type of glomerulonephritis, that is acute post-infectious glomerulonephritis. This is another form of glomerulonephritis. Acute condition, post-infectious glomerulonephritis, that is occurring after the infection. It is the most common following any kind of infection with certain strains of streptococcus, and therefore it is often called as post-streptococcal nephritis. So it is most common and following any kind of infections with the strains of streptococcus, and therefore it is called as post-streptococcal nephritis. It is more common in children, and latency is about 10 days after the throat infection or longer after the skin infection. So there is latency of about 10 days after the throat infection or longer after the skin infection, that is producing acute post-infective glomerulonephritis, throat infection or the skin infections. It is rare in developed world. Compared to IgA nephropathy, it is more common. It suggests an immune mechanism rather than direct infection. So it suggests an immune mechanism rather than the direct infection. The symptoms of acute post-infectious glomerulonephritis includes sodium retention, there is hypertension and edema. There is reduction of the glomerular filtration rate, proteinuria, hematuria, and reduced urine volume. So symptoms, we have sodium retention, hypertension, and edema. Sodium retention, hypertension, and edema. We have reduced GFR, proteinuria, hematuria, and reduced urine volume. The urine has a red and smoky appearance. There is low serum concentration of C3 and C4. The evidence of streptococcal infection ASO titer, culture of throat swab, and the other microbial sampling is present. Now, how will you manage the case of acute post-infectious glomerulonephritis? The management is done by fluid and sodium restriction and the use of diuretic and hypotensive agents. The treatment consists of correlation of the fluid and electrolyte imbalances, and it usually resolves spontaneously. So the management is by fluid and sodium retention and the use of diuretic and hypotensive agents. The treatment consists of correction of fluid and electrolyte imbalances, and it resolves spontaneously. Next, we come to the rapidly progressive glomerulonephritis. Rapidly progressive, as the name suggests, it is progressing rapidly. It is an extreme inflammatory nephritis which causes the rapid loss of renal functions over the days to weeks. So it is the rapidly progressing glomerulonephritis that causes rapid loss of renal functions over days to weeks. It is there is a subacute reduction of the GFR of greater than 50% with evidence of proliferative glomerulonephritis. So there is subacute reduction in the GFR of greater than 50% with evidence of proliferative glomerulonephritis. It causes overlap with those of acute glomerulonephritis. There are three major subtypes of rapidly progressive glomerulonephritis on the basis of renal biopsy findings and pathophysiology. So, rapidly progressive glomerulonephritis can be divided into three major subtypes on the basis of renal biopsy finding and pathophysiology. We have immune complex association, example in systemic lupus erythematosus, SLE. It can be pauci-immune. First of all, immune complex, that is totally immune. The second is pauci, that is small, few, immune associated with anti-neutrophil cytoplasmic antibodies, that is ANCA. And third one, it is associated with anti-glomerular basement membrane antibodies, that is anti-JV'n antibodies, example in Goodpasture syndrome. These we are going to discuss in the consecutive coming slides. Now we start with SLE. SLE is systemic lupus erythematosus, or simply called as lupus. There is renal involvement. It is due to the deposition of circulating immune complex. So SLE was related to the immune complexes, deposition of circulating immune complexes. There is non-renal symptoms of SLE. It includes arthralgia, butterfly, skin rash, serositis, alopecia, hair loss, and central nervous system disease. All these symptoms we have already discussed in dermatology of SLE. Nephrotic syndrome with renal insufficiency is common. Renal biopsy reveals mesangial, focal, or diffuse glomerulonephritis and membranous nephropathy. So in SLE, we have deposition of circulatory immune complexes. Other symptoms include arthralgia, butterfly rash, serositis, alopecia, and central nervous system disease. There is renal insufficiency is common, and renal biopsy reveals mesangial, focal, diffuse glomerulonephritis, and membranous nephropathy. SLE is characterized by active sediments, severe proteinuria, and progressive renal insufficiency. So there is deposition of the sediments. We have severe proteinuria and progressive renal insufficiency. The treatment includes glucocorticoids and cytotoxic agents. Oral or intravenous monthly cyclophosphamide for a period of 6 months. This is the treatment of choice in case of SLE or lupus. Next, we come to the ANCA, that is anti-neutrophil cytoplasmic antibody or focal segmental necrotizing glomerulonephritis. This is another form of glomerulonephritis, that is focal segmental necrotizing glomerulonephritis. It is defined, there is a defining characteristic is the presence of circulatory ANCA. So the name is focal segmental necrotizing glomerulonephritis, and it is characterized by the presence of circulating ANCA, that is anti-neutrophil cytoplasmic antibody. These are detected by immunofluorescence of alcohol-fixed neutrophils. The symptoms include prodromal flu-like syndrome, which may encompass myalgias, fever, arthralgias, anorexia, and weight loss. So there can be myalgia, fever, arthralgia, anorexia, and weight loss. The treatment of the rapidly progressive glomerulonephritis includes methylprednisolone and cyclophosphamide, corticosteroids, and cytotoxic agents. The segmental inflammation and or necrosis in the glomeruli, and small vessel vasculitis. Next, we come to the antiglomerular basement membrane disease or the good pasture syndrome. So the good pasture syndrome, it is also known as the antiglomerular basement membrane disease. It is characterized by antibodies against the alpha-3 NCI, circulating anti-GBM antibody, and linear immunofluorescence on the renal biopsy establishes the diagnosis. So diagnosis is established by circulating anti-GBM antibody and linear immunofluorescence on the renal biopsy. Good pasture syndrome encompasses glomerulonephritis and lung hemorrhage. The treatment of the good pasture syndrome is done with the corticosteroids, cyclophosphamide, and plasma exchange to remove circulating antibodies, autoantibodies. So this is again the same picture that we have discussed. Nephrotic syndrome, we have discussed about minimal change nephropathy, FSGS, membranous nephropathy, amyloid. We have discussed about diabetic nephropathy, MCGN, post-streptococcal glomerulonephritis, small vessel vasculitis, and anti-JV'n disease, that is good pastures disease, and also nephritic syndrome. So all these we have already discussed, and this completes our glomerulonephritis. So this was all about the genitourinary system. We will start with the next chapter of neurology from the next lecture. This session was powered by Digital Version 2.0, JAYOTI VIDYAPEETH Women's University. I hope you are satisfied with my digital session. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. We will be meeting in the next lecture tomorrow with a new chapter. Thank you.